now we focus on the disease IPF, that is idiopathic pulmonary fibrosis. So the disease is unknown causes. It has a chronic progressive fibrosing interstitial pneumonia and occurring primarily in the elder people, normally about 50 years. And its histopathologic or radiologic pattern is UIP, and the incidence is very low. It's about 6.8 to 16.3 in 100,000 people. This is the data from America, and normally male is more frequent in female, and the survival rate is very low. The 5-year survival rate less than 50%. So we talk about potential risk factor for ILD. It's same for the IPF. So cigarette smoking, environmental exposure, and microagent such as Epstein-Barr virus or hepatitis C is very dangerous. Is very harmful for the lung, and the gastroesophageal reflux is very important for develop ILD or IPF. And in IPF, it's very specific for a genetic factor, that is ELMOD2 in chromosome 4q31. So the pathogenesis of IPF, so people normally has a genetic suspectability. Maybe they have MUC5B, TOLIP gene, SPC, or TERT. So when something, so particulars, chemicals, autoimmunity, viral, all these injuries will active coagulation cascade, antioxidant pathway, or fibrocyte circulating cells, or macrophage stimulation. All this can cause imbalance from the pro-fibrotic mediator and anti-fibrotic mediator. So you can see CGEF, TGF-beta, PGGF, or VGGF increase, but the anti-fibrotic mediators, PGE2, IFN gamma, HGF decrease. So this leads to the endothelium, epithelium, fibroblast activity, and they transdifferentiation, proliferation, apoptosis, and extracellular matrix turnover. And the end will be excessive extracellular matrix deposition and fibrosis. So the histopathology feature of IPF is evidence of marked fibrosis architectural distortion and honeycombing in a predominantly subpleural paraseptal distribution, and presence of patchy involvement of lung parenchyma by fibrosis. And very important is the presence of fibroblast foci and the absence of feature against a diagnosis of UIP, suggesting an alternative diagnosis. So this is picture to show the histology of the IPF. So the picture A is scanning power microscopy show a patchy process with honeycombing space. So some reversed lung tissue region and fibrosis into the lung from the subpleural region. And in the section B, adjacent to the region of more chronic fibrosis is a fibroblast foci, and recognized by its converse shape and composition of edematous. And the clinical presentation of IPF, first of all, so you have to pay attention to the age. If the patient less than 50 years old, your normally cannot be diagnosed as IPF. So they have unexplained chronic externation dyspnea and cough, and you can find inspiratory crickles we called Velcro and clubbing fingers. And for the majority of patients have a history of cigarette smoking. And the chest image is very important. For the chest X-ray, you can see reticular abnormality or ground glass opacity and subpleural basal predominance or honeycombing. But now we need a HRCT, high resolution CT, to show the UIP pattern. That is very important. You can see subpleural basal predominance and reticular abnormality, honeycombing with or without traction, bronchiectasis, and absence of features listed as consistent with UIP pattern. So this picture showed subpleural basal predominance reticular abnormality. So this is subpleural reticular linears. And this showed subpleural basal predominance reticular abnormality. So you can see honeycombing in the arrow. So other detection, we can see the pulmonary function test. You can find restrictive ventilatory disorder, decreased lung compliance, and decreased DLCO. For the blood gas analysis, you can find decreased PaO2. So at the end phase, you can find increased PaCO2. In the blood, you can see ESR increased, IgE increased, and positive for ANA or RF. And for the bronchoalveolar lavage or TBLB, now should not be performed in the diagnostic evaluation of IPF. And if the patient HRCT show possible UIP, so this patient should undergo a surgical lung biopsy. So the diagnosis of IPF, we have three kinds of standards. One is exclusion of other known causes of ILD, such as occupational environmental exposure, connective tissue disease, or drug toxicity. And two is presence of UIP pattern on HRCT in patients not subject to surgical lung biopsy. And three, the specific combination of HRCT and surgical lung biopsy pattern in patients subject to surgical lung biopsy. So this picture is the typical HRCT for IPF. And in the right, they show the bronchoalveolar lavage. The right side is the color. In the right is IPF. And for the treatment, also have non-pharmacotherapy and pharmacotherapy. For the non-pharmacotherapy, we need lung transplantation, long-term oxygen therapy, and pulmonary rehabilitation. And for the pharmacological therapy, is very important. This is anti-fibrotic medicine for nintedanib and pirfenidone, and anti-acid medicine, and acetylcysteine. So that's it. This four kind of pharmacotherapy is very important for IPF management. So that's all for today. Thanks.